Hello, my name is Jesse Valent. I am an evaluator in the Department of Health and Human Services, Office of Inspector General. Our mission is to protect the integrity of HHS programs and also the health and welfare of the beneficiaries served by these programs. OIG is committed to working with IHS to strengthen patient care in IHS hospitals. Through our studies and evaluations, we identify specific opportunities for improvement by IHS. IHS uses the findings from our studies as the jumping-off point to make changes to enhance quality and patient safety. In this video, I will review findings and recommendations from two recent studies. The first study is incidence of adverse events in Indian Health Service hospitals, and the second study is instances of IHS labor and delivery care not following national clinical guidelines or best practices. Although OIG has studied IHS's overarching operations in the past, these two studies were the first to focus specifically on patient safety and adverse events in IHS hospitals. Before diving deeper into the specific results from these two studies, let me provide you with some context. First, some context specific to IHS. In fiscal year 2017, the time period considered in our studies, IHS was providing comprehensive federal health services to approximately 2.6 million American Indians and Alaska Natives. IHS provides acute care services at about 24 hospitals located mostly in remote areas across the country. Most of these hospitals are small, with few inpatient beds. Like most rural hospitals, compared to acute care hospitals nationally, IHS hospitals have lower patient volumes, provide less clinically complex care, and have shorter average lengths of stay. Prior OIG reports have identified longstanding challenges to delivering safe and high-quality care to American Indians and Alaska Natives. These challenges include staffing shortages and lack of specialty care. Now, let's talk a bit about adverse events and the patient safety movement more broadly. Reducing the incidence of adverse events is a critical step to improving patient safety and quality of care. In the year 2000, the Institute of Medicine, also known as IOM, published the book To Err is Human, Building a Safer Health System, focusing attention on the problem of adverse events. IOM cited two medical record reviews that estimated that adverse events caused between 44,000 and perhaps as many as 98,000 deaths in hospitals each year. Prompted in part by IOM's work, Congress passed legislation requiring that OIG study patient harm events. Beginning in the year 2008, OIG released a series of studies regarding adverse events, including 5 reports that estimated incidence rates in a variety of healthcare settings. In a 2010 study, OIG found that 27% of hospitalized Medicare beneficiaries experienced adverse events or temporary harm events, and that about half of these events were preventable. For more about what OIG found in other healthcare settings, including skilled nursing facilities and long-term care hospitals, please see the reports linked below. Each of the OIG studies that estimated incidence rate used a methodology that included, first, nurses screening records for potential harm events using the Global Trigger Tool, or GTT, followed by a second review by physicians to identify and confirm the harm events. Other researchers have used variations of the GTT methodology and found estimated harm rates ranging from 9% to 33%, depending on the population being studied and the methodology being used. These studies can be found in the resources linked in this video. Now on to the two studies I introduced earlier. The first study, Incidence of Adverse Events in Indian Health Service Hospitals, looked at the prevalence of patient harm in IHS hospitals. We identified adverse events, which are patient harm events that result in prolonged hospital stays, lead to permanent patient harm, require life-sustaining interventions, or contribute to death. We also identified temporary harm events, which are events that result in patient harm and require medical intervention, but do not cause lasting harm or result in prolonged hospital stays. Although these events were ameliorated before they could cause further harm, they can still be very serious. We also assessed whether the patient harm events would have been preventable had the patients received better care and what factors contributed to the events. So what did we find? We found that during their stays in IHS hospitals, 13% of patients experienced adverse events or temporary harm events. 4% of these were adverse events, and the remainder were temporary harm events. In other words, roughly 1 in every 8 IHS patients experience some type of harm during their hospital stays. More than half of the events were related to medication errors. Let me give you a few examples of these. In one case, an older patient was given too much medicine for cramps and insomnia. That night, the patient woke up confused, a known side effect of the medicine, and fell out of bed. Afterwards, the doctor discontinued the specific medication. In another case, a child came to the hospital because he had trouble breathing due to chronic respiratory disease. Doctors gave him a medicine intended to decrease inflammation in his respiratory system and relax his airways so he could breathe more easily. Unfortunately, the doctors gave the child an overdose of 5 times the amount of medication that he needed. This overdose led to the child developing diarrhea. After the staff recognized the error, they called poison control, and the child received treatment for this medication overdose. In addition to medication events, we grouped events into 3 other clinical categories. First, patients also experienced harm related to routine patient care, such as nursing care. For example, some patients experience allergic reactions or IV infiltrates. An IV infiltrate is when the IV fluid escapes into the surrounding tissue from the site of the IV. Other patients experience infection events, such as infections at surgical sites, and then a final category of events related to procedures, such as an unintended laceration during surgery. One of our most important findings was that about half of the patient harm events we identified could have been prevented if the patients had been given better care. One example of a preventable event involved a delay in diagnosing and treating hypercalcemia or high calcium levels, which can be quite painful and can be treated quickly with saline. The patient, who was ultimately diagnosed with blood cell cancer, was admitted for abdominal pain, had significant hypercalcemia, unexplained anemia, and kidney failure. Despite classic symptoms, providers did not diagnose the patient's blood cancer. Our physician reviewers determined that the misdiagnosis was clearly preventable because the providers at the hospital had the information they needed to make an accurate diagnosis. The patient was then transferred to a second hospital where both conditions were promptly diagnosed. This case is an example of both substandard care and errors in medical judgment. The other half of patient harm events in our study were not considered preventable for a variety of reasons. Almost half of these non-preventable events occur because the patient was susceptible to the harm events due to poor underlying health. For example, one case involved a patient who was terminally ill and immobile. Due to the patient's immobility, the patient developed pressure ulcers, which are an adverse event. In other cases, events occurred despite proper assessment by providers and procedures being properly followed by providers. As a result of our study, we recommended that IHS take several actions. First, we recommended that IHS make patient harm monitoring and reduction a key priority for its new Office of Quality. This includes monitoring patient harm events in the IHS incident reporting system. Ideally, doing so will help IHS and hospital leadership set goals for quality improvement, direct resources towards these efforts, and evaluate whether the efforts are successful over time. So what can you do to help achieve this goal? Patient harm monitoring and reduction should be a top priority for you as well. Perhaps most important to this effort is making sure accurate information about patient harm events is collected. If you suspect or are aware of a patient harm event, we encourage you to report it. We also recommended that the IHS Office of Quality produce educational materials on adverse event to include definitions of what constitutes an adverse event and a list of potential or likely adverse events, ways to reduce adverse events, and best practices to track those events that do occur. How can you contribute to this effort? As these materials become available, please read them and take any trainings that your facility offers. Doing so will ensure that you stay up to date and knowledgeable about adverse events. Another important finding from our study was that patients in smaller IHS hospitals, older patients, and labor and delivery patients are more likely to experience adverse events. Based on this finding, we recommended that IHS develop quality improvement plans targeted specifically at these groups and at other high-risk populations. The groups at highest risk for harm may vary from facility to facility, depending on the patient population and the kinds of services provided at a given facility. If you are working in a healthcare facility, please consider which plans best address the patients your facility serves. taking into account your patient's specific areas of risk as identified through measuring and monitoring systems. Now let's talk a little bit about the second report we produced, which is instances of IHS labor and delivery care not following national clinical guidelines or best practices. The study of adverse events that I just described included several labor and delivery patients. During medical record review for the full adverse event study, we found several examples of providers not following national clinical guidelines or best practices while providing labor and delivery care. We also noted a higher than expected number of postpartum hemorrhages or excessive bleeding after giving birth. This surprised us, but postpartum hemorrhage may be more common among American Indian Alaska Native people. Overall, pregnancy-related deaths for American Indian Alaska Native people is 2 to 4 times higher than for other women. To improve these outcomes, we must understand their underlying causes. This study of labor and delivery practices is one step in that process. Based on our initial findings, we felt it was important to share this information with IHS, so we decided to conduct this second, smaller study that looks specifically at IHS labor and delivery practices. Using a protocol designed to capture instances where providers did not follow national clinical guidelines, especially those guidelines related to inducing labor, diagnosing and treating hypertension preeclampsia, and performing cesarean sections, and also looking for instances where providers did not follow a best practice associated with diagnosing and treating postpartum hemorrhage. Our physician with expertise in labor and delivery reviewed the medical records for the 48 labor and delivery patients included in the original sample. When we talk about national clinical guidelines, we are referring to widely accepted clinical standards written by groups such as the American College of Obstetricians and Gynecologists, also known as ACOG. The national clinical guidelines cover topics such as prenatal care, diagnosis and treatment of postpartum hemorrhage and preeclampsia, and induction of labor. Overall, our review found that slightly more than half of the labor and delivery patients we studied had some aspect of care that did not follow national clinical guidelines or best practices. In some instances, this care contributed to temporary harm events such as excessive bleeding due to improper diagnosis and treatment of postpartum hemorrhage. However, most patients who received care that did not follow national clinical guidelines or best practices did not, in fact, experience a harm event. We also learned that at the time these patients received labor and delivery care, several IHS hospitals did not consistently follow best practices for diagnosing postpartum hemorrhage. Specifically, these hospitals were not using quantitative estimation of blood loss, a technique that is less subjective than the alternative of visually estimating the amount of blood loss. The better practice of quantitative estimation of blood loss can lead to quicker diagnosis and treatment of postpartum hemorrhage. While following clinical guidelines, such as administering the appropriate starting dose of medication when inducing labor, is expected for all physicians, following best practices is a higher, more aspirational bar. We made 3 recommendations to IHS to focus their attention on labor and delivery in their facilities, including conducting an assessment of labor and delivery practices, providing guidance and technical information about diagnosing and treating postpartum hemorrhage, and ensuring that all hospitals implement the Alliance for Innovation on Maternal Health bundles of best practices. These bundles are sets of best practices, each of which is specific to a maternal health condition. If you are a care provider in any facility, please pay attention to the clinical standards and best practices that are appropriate for your field. When these are not being followed, please notify clinical leadership at your facility and ask how you can ensure that patients are getting the highest level of care possible. Thank you very much for the opportunity to share the results of OIG's work with you. At OIG, our commitment to monitoring and helping to improve the quality of care at IHS facilities continues.